Irina, you're most welcome. Thank you. Hello, dear colleagues. I'm happy to welcome all of you. Thank you for finding time to join our webinar about current methods of diagnosis and therapy for cancer patients. And this webinar is provided by Datar Cancer Genetics Europe company. It's the laboratory integrated technological platforms are integrated. There is a bioinformatic teams, a huge genetic database there, and this is the laboratory center, research center accredited by ISO 15189, and the services of this lab are used by national, international research institutions, as well as patients from the US, Switzerland, Germany, UK, and they are located, the main labs located in the UK and India. And thanks to the newest technologies that exist today, these technologies exist in these labs, and they offer highly efficient solutions to treat cancer patients, including those patients for whom other treatment lines were not efficient. I wanted to introduce Dr. Stefan Schuster to you, and he has more than 17 years of experience in diagnosis and developing assays, and 13 years he's been specializing on technologies of circulating tumor cells and liquid biopsy, and his research encompasses the whole spectrum, translational spectrum of diagnosis, from biomarkers to validation to clinical application at early stages of cancer monitoring, cancer therapy management. Dr. Schuster has a PhD in chemistry and pharmaceutics and a lot of experience in molecular oncology and clinical diagnostics, author of more than 50 articles about liquid biopsy technologies and personalized cancer treatment. And besides his research and scientific input, also he is the director of Datar Cancer Genetics Europe, and he controls scientific and strategic approaches of this company's work. And we were happy to initiate our cooperation with this wonderful Center of Molecular Diagnostics. It allows to provide our Ukrainian patients to have access to the most current methods of diagnosis, and hopefully saving a lot of lives. Dr. Stefan, most welcome.
Kind introduction. I will start now the presentation. Just let me check if you can see everything. Is everything fine, Irina?
Yes. Yes, it's okay. Yes.
Perfect. And also, please let me know if the translator needs a little bit more time, or if everything is all right. So thank you very much for the kind introduction, Irina. I think she already said everything you need to know about myself. Maybe just a short introduction also about the company, and thank you again for joining us today. Datar Cancer Genetics itself was founded in 2013. At the moment, we are approximately 200 people worldwide working for Datar Cancer Genetics. And together with my team, we are responsible for Europe, but also for other countries, South America, Australia, etc. So today I will talk about comprehensive tumor testing. And before doing so, I want to give you a short overview about our portfolio. So very clearly, we have a two-divided portfolio for the patients. One side is where cancer hasn't been diagnosed. This is basically screening tests, but I don't want to go into details here because today we will speak especially about those tests over here where cancer has been already diagnosed. We are focusing on solid tumors only, so we don't look at hematological diseases. We only are focusing on the typical lung cancers, breast cancers, but also sarcomas, melanomas, glioblastomas, etc. And what we offer here is on one side a typical tissue-based test, which is part of the EXACTA test. Actually, the EXACTA test was the reason why I joined 7 years back the company, because it was the first test that I have seen which is able to combine both tissue plus liquid biopsy. So we will get, if tissue is available, the information which is available from the tissue, maybe from the last biopsy, maybe from the last surgery, but also in addition, the information which is present in the blood, the CTCs, the circulating tumor DNA, and so on, to get a very, very comprehensive overview about what is going on in the particular patient. Then we have another part of the EXACTA test, which is the chemoscale test, where we can check directly the efficacy of chemotherapies, carboplatin, cisplatin, etc., where we are testing approximately 30 substances. But if necessary, we can also, if asked, we can also test here complementary substances. Of course, we have many more tests in this field, but I want to focus here only on those and especially on the EXACTA test. And then we have also monitoring tests, which are very valuable. Meanwhile, because you can check, meanwhile, with very sensitive methods, not just using imaging, but blood-based methods for ctDNA. You can apply different methods for ctDNA. Here we apply NGS. Here we, for this molecular residual disease test, which is also called CancerTrack MRD, we are using circulating tumor DNA, but we are using in addition digital droplet PCR to gain a higher sensitivity, and everything is based then on a tissue gene panel that was performed upfront, but I will tell you details later on in the talk. So, why is it very important to have comprehensive tumor testing? On one side, and I think you are all aware of this, we observe a spatial heterogeneity. So it depends, where do we observe the primary tumor, where do we have the metastasis, are the metastases in the brain, in the lung, etc. So simply because of this, we see heterogeneity. But then also we see tumor evolution. And during the tumor evolution, also after each line of treatment, cancer is changing. And we need to adapt therapy if we observe a relapse, because it will definitely be not the first. The relapses will not have the whole properties like the first tumor which was observed. And then, of course, we see intratumoral heterogeneity, what you can see here. This is basically the biggest challenge that we observe, that already the primary does not have only clonal cells, but we see here several different subtypes, which are sometimes difficult to treat. And when you get a lot of information, like with our EXACTA tests, you can better judge what you have in front of us and better treat the patient. I will show you details later on. But also what we have observed and what we learned over the years is 20 years back when Hanahan published the first hallmarks of cancer, we observed only 8 hallmarks of cancer. Now we know in 2022 that there are several cancer-relevant pathways, from avoiding immune destruction, tumor-promoting inflammation, that we now see phenotypic plasticity, non-mutational epigenetic reprogramming. So we know more and more about the cancers itself. And what we also have learned very clearly, it's not sufficient to target with one drug just one of those pathways. But it is very important to tackle the tumor from different sides to have afterwards successful therapy, or to increase at least the possibilities of a successful therapy. And also what we need to take into account, and this is why I'm showing now this clinical trial, which was just published in 2026, and those, well, precision oncology trials have been ongoing now for quite a while. What is very important to know that 95% of the patients have a molecular unique tumor. So really each tumor is different from the other one. And this is why we also, when we look at the older trials that we were pursuing so far, we have a very heterogeneous group of patients in those trials. And now we need to understand how can we adapt upcoming new trials to have a meaningful outcome and to really tell to the individual patient if you have an advantage. And what was done, especially in this trial, was also, and what we are doing also in our trials, to compare the patients with themselves. Those are usually the patients that have usually already a relapse, and we are comparing the time to relapse from start of the treatment and to see if we can prolong the time to relapse. Because usually time to relapse is getting shorter and shorter and shorter with each treatment. And here we try to break this vicious circle using new methods, new molecular methods to understand the tumor much better. Now coming to EXACTA. What does EXACTA do? On one side, we have two choices for EXACTA. One is tissue plus blood analysis. And if new tissue or tissue is not available at all, we can also focus on blood only. However, if possible, we would prefer to always have tissue available. And then we are doing normal gene analysis, like what Foundation is doing, like what other tests are doing. We are looking for fusions. Here, it already gets a little bit different compared to other tests. We are checking the transcriptome for all 20,800 genes to establish a framework which pathways are maybe overexpressed or underexpressed, and based also on this to give certain recommendations. Then we are looking for tumor mutational burden. If we don't have the tissue, we are looking for blood tumor mutational burden. We are looking for microsatellite stability. We are looking for immunohistochemistry. Of course, immunohistochemistry is not available over here in blood-based tests. We are looking, when we just have blood, for mismatch repair proteins using germline DNA. We are analyzing immunocytochemistry on circulating tumor cells. I will tell you details about this, but also pharmacogenetics, because we have quite frequently also patients that have issues with side effects. And sometimes the pharmacogenetic analysis will give you details about this. Or if you have a breast cancer patient which relapsed on tamoxifen and finally you find a ZIP mutation, then there is very likely a connection in between this mutation that we have found and the not working of tamoxifen, for example. Also for other drugs, pharmacogenetics might play a bigger role than what we initially think. Actually, over the past 20, 25 years already, when I was studying pharmacy, pharmacogenetics in 2003 to 2004 played a very big role. And when I was a student, we did, for example, a test of the germline DNA, and what we have found, 70% of my colleagues have had abnormal metabolizer status for different drugs. So it's something which is very, very common. Then, of course, we are doing BRCA testing where applicable, mainly in the breast, ovarian, prostate, to check if a germline mutation is there or not. We are checking here the whole genome, the whole gene with all exomes. Then we are doing circulating tumor cells. I know those are quite frequently discussed, but I will give you details how we are doing this. We are testing then on those circulating tumor cells drugs to check for the efficacy. And yes, those are the panels that we are doing. The main important thing that I want to show you here in this particular slide is, of course, we have different processes, how we are testing then targeted treatments, endocrine treatments, cytotoxic treatments. And what we have seen when we find only and apply only afterwards chemotherapies, then the efficacy, the potential of the treatment is usually much lower compared to when we can combine a targeted treatment with a chemotherapy or two targeted treatments with a chemotherapy. We have here a higher efficacy when we are able to combine targeted treatments and chemotherapies. This relates directly to what I said initially, that we need to target the cancer from different pathways to have a success. The challenge that we observe, of course, is the higher the combinations, the higher the toxicity risks, the higher the drug interactions. And this is where we have to take care. However, meanwhile, we have specialists in our group. We have specialists among our users that know very well how to combine those drugs with what kind of concentrations you need to go into these particular patients where you apply a 3-drug or 4-drug regime. So if you have questions on this, we can definitely bring you into connect with some of our specialists that can tell you then specifically about this topic, how they're moving forward in this particular direction. Because it's a very highly discussed topic, I want to talk a little bit about our circulating tumor cells and our methods. Very clearly, what are circulating tumor cells? Those are the cells that you find in the peripheral blood, and you can detect some of those cells for up to 10 years, 15 years after the initial diagnosis, even when you haven't had any relapse in between. So they can recirculate for a very long time. However, the majority of those cells usually will last only between 2 to 6 hours, dependent on the publication that you are looking at. And then there are different methods. I don't want to go into detail here. However, one of the most used methods is using magnetic beads directed against EpCAM or cytokeratin that will collect the cells with the magnetic force out of the sample. However, the issue here is, especially with the most common method, which is called cell search, that you fix the cells up front, and fixation of the cells destroys 90% of the cell surface. And this is the issue when you apply then magnetic beads targeting surface proteins like EpCAM. You will lose a lot of cells, and this is why you think, or at the moment, it's very well known that you find only very few cells. However, this is not true. You find much more cells in the circulation when you apply different methods. And here I want to show you specifically our method, what we are doing. So again, coming back to the initial thoughts, one of the central hallmarks of cancer is apoptosis resistancy of cancer cells. And this is what we are using here to detect those CTCs. So what we are doing, we are using EDTA blood, get rid of the red blood cells and harvest the PBMCs and put them in a short-term media. And this short-term media consists of apoptosis activating factors like cytokines, like Janus kinase activators. And after 5 days, only apoptosis resistant cells, among them EpCAM positive cells, cytokeratin cells, but also we find clusters, as you can see here, which consist of tumor-associated lymphocytes, tumor-associated macrophages, etc. that travel all along in clusters. Also very important to note, we don't see any proliferation here. So the genotype of those cells that we are finding here is not changing, very important. And those cells can be tested then afterwards, after 5 days approximately. And we have performed clinical trials looking especially on the efficacy of chemotherapies. If we can check on those circulating tumor cells, really, if they react to the chemotherapies, and we can compare the result there then afterwards with the in vivo response in the particular patient. And what we have seen, especially in pre-treated patients, that when the drug is not working on the particular CTCs, we have only a very low efficacy, then we have a concordance with in vivo treatment failure of 87%. The same is true on the other side when we look from the positive side. When it works in the particular patient, it will initially also work. When it will initially work on the circulating tumor cells, it will also work in 90% of the patients afterwards. But we have to be very careful, because especially in metastatic settings, when you only look at chemotherapies alone, you will see a relapse 9 weeks, 16 weeks, sometimes half a year, but you will see a relapse in almost 70-80% of the metastatic patients if you rely only on chemotherapies. What we did also in a certain subset was to compare the efficacy of fresh tissue taken directly from the patient. We have had here 140 patients where we have had fresh tissue, and to compare it with the blood. And it's not surprising that we don't have a 100% concordance because of the heterogeneity, but we have had a concordance of approximately 94% in those patients. So we are very sure that when we see a response in the circulating tumor cells towards a chemotherapy, then the chance that it's working is much higher compared to a drug where it's not working. And so we are changing the statistics in favor for the patient. Just to let you know here some details, how many patients we have had, etc. So approximately we have had 5,000 patients. We have had also therapy naive patients and pre-treated patients. What's interesting to see definitely is that pre-treated patients, you see a much higher resistance towards chemotherapies compared to therapy naive patients, which is not really surprising, that if you have a pre-treated patients, you already have a special subtype of cells that have developed a certain resistance. And also you can see here we have different types of cancer: breast, cervix, colorectal, head and neck, etc. And also we have published over the years several abstracts. By the way, at the moment we have an ongoing clinical trial in Tel Aviv for pancreatic patients, just focusing on chemotherapies. They are aware about the certain limitations of a test only focusing on chemotherapies, but the advantage in Israel is that each patient gets a full genetic analysis of his or her tumor, which is why they are not in a big need for a comprehensive test like EXACTA, because part of the data is already there. This is also something, because no one else is doing this, like what we are doing here, that we are checking also the immunocytochemistry on those particular circulating tumor cells. And what you can see here, that we have basically a very good accuracy when it comes to PD-L1, when it comes to ER, PR, HER2, etc., all between 77 and 92%. So we are very sure that those cells that we are finding are definitely coming from the tissue. Also, what I'm not showing today, however, we also checked in the circulating tumor cells the DNA. And we see here a concordance between circulating tumor cells and tissue around 88% that they share the same genetic outfit compared to the tissue. This is also why we are very sure that they're really coming from the initial tissue, the CTCs. Those are the pathways. This is actually what you get in the in one of our reports, in the EXACTA reports, to have an mRNA quantification from exosomes or from the tissue, and where you can see an underexpression for certain genes, or in red, a certain overexpression, like here from MMPs, an overexpression, or HER2, an overexpression. And then we will go into detail if some of those pathways are relevant for therapy in the particular report. What I feel is also one of the most important biomarkers, because we in the blood, because we as a company focus a lot on liquid biopsies. However, we have, I think at the moment, 5 pathologists also on board, which are working for us to analyze just the tissue. ctDNA is another important marker, because you can use the ctDNA to check for, on one side, to check the progress of the disease, the efficacy of the treatment, but also you can check if certain mutations are present that can be used for as a predictive tool in the future. Maybe some interesting side information on this. You should look very closely at the impact on sequencing death for SNVs. Why? Because only then, if you have a high sequencing death, which is up to 70,000x in our cancer track test, which is also used in EXACTA, only then you can find rare mutations or mutations which are present only at a very low variant allele frequency. So this is something you should look at when you're judging other tests. We can leave this away. I just wanted to depict here that you can find mutations both in tissue and in blood, but there will be always tissue unique findings and ctDNA unique findings. And meanwhile, when you look at the ESMO guidelines, for example, for PIK3CA or ESR1, ctDNA is a very important marker because you can act upon it. So please forgive me if we don't go into super depth into our clinical trials for EXACTA. Just we will see some slides here. One important study which was published in 2019 was the Resilient trial. I will tell you some details about this. Finally, we have had 126 patients included in this trial, which were treated in accordance to EXACTA. Important to know, in 2019, we did not include yet the immune checkpoint inhibitors. Those came only later in the liquid impact trial, or they play a role in the real world data that we have recently published in Germany. What we have seen in those patients that were heavily pretreated, so on median, they have had at least 2 different therapies already, that we could see a partial response or a complete response in 54 patients, but also important to note that we have had a disease control rate in 90% of the patients. So in 90% of the patients, we were able to stop the disease. The liquid impact trial focuses. In the resilient trial, we have had tissue plus blood, liquid. We only looked at the blood. Unfortunately, this was performed during COVID, and we have had only 26 patients included in the trial, in this interventional trial, but also here we have had an objective response rate of 46% and disease control rate of 88%. And the median overall survival in this heavily pretreated patient group was 8.8 months. Then we just published last year some data from Germany with 44 patients, and 70% of the patients improved their progression-free survivals with unchanged ECOG status. Also very important, because usually you would think that the patients are deteriorating, or because of more side effects, they would become worse. But in this case, in 70% of the patients, their ECOG status remained the same. Also, what is very important to note, that the progression-free survival after EXACTA was 30 weeks, and the progression-free survival before the treatment until the patient relapsed was 22 weeks, which was a significant outcome, which again showed that you can really prolong the life of the patients using those tests. And also what was very important here of the patients, we have seen that a certain subgroup of around 30% of the patients live longer than 2 years. We are following up those patients at the moment. What is different for them? Why did they respond better? What was the reason? Maybe we will have an answer in 1, 2, 3 years. Let's see. And then we have had 2 other clinical trials with using angiogenesis inhibitors, where we also found a disease control rate of 95%, that we have had a median progression-free survival of 5 months and overall survival of 8.9 months. What did we do here? We looked at patients that have specific molecular markers for PIK3CA or for bevacizumab, and where we could combine them with other drugs that we have found within EXACTA. Because when you look at bevacizumab, for example, alone, it's a not very successful drug. But what we have found here, that if you are able to combine it in an intelligent way, you will see a lot of patients benefit from it, because, and which is shown here with a disease control rate of 95%. The same systematics we applied here for this clinical trial for mTOR signaling pathways, where we have had 46 patients, also an objective response rate of 57% with everolimus plus an intelligent combination. Just let me show you maybe here some details for the resilient trial. So it was published in 2019. And actually, when I saw those results back in 2018, I thought, well, it's definitely worth to join the company, especially with those patients that have had multiple treatments already. And this is where we checked progression-free survival versus time to progression. And the factor was 2.5%, or 35% of the patients have had a factor of 2.5 compared to the previous therapy, where they got better. And 75% of the patients have had a progression-free survival bigger than, or where the factor was 1.3. And also here you can see the Kaplan-Meier curve in those patients. So there's still more or less, there are still patients that we can follow up. This is also what we see more or less in our German real-world trial that survive for a very long time, even if they have had several treatments up front. The liquid impact trial, I've already have been talking about this. It was published in 2022. Also, big difference here was that we were able to apply immune checkpoint inhibitor therapies. What we have done was putting together some of this data. Just let me show you here some outcomes when we combine both resilient liquid impact, and we have had from UK some non-study patients. And what was the outcome here? So because we applied in all of those patients more than one treatment, usually. So not just chemotherapies, but targeted treatments plus chemotherapies, etc. We did not see any severe side effects. So we have had, even when you look at this group, that have had 2 targeted treatments or 3 targeted treatments plus chemotherapy, we have had in the majority only grade 1 adverse events, and only in a minority we have had grade 4 adverse events, which is pretty good if you compare it, for example, only to the chemotherapy alone group, where we observed only the triple-fold number of side effects, grade 4. And what were the survival metrics? This is what I've already have said before. It's more or less, when you look at the progression-free survival, it's much higher in those groups where we can apply more than one targeted treatment in combination with chemotherapies. Of course, this group was pretty small with 6 individuals. The majority received 2 targeted treatments or 1 targeted treatment each plus chemotherapy. And we have seen here a median progression-free survival across all the group of 4.8 months and a median overall survival of 8.0 months. But what is again interesting here, that we have had a median overall survival in this particular group of 11 months. And this is also what is depicted here. This is the Germany, this is the real world data. This is the poster that we have shown quite a while ago on a congress. This is where it's still 42 patients. Actually, we published 44 patients finally, but the outcome did not change much. It's just to show you that 12% of the patients received only chemotherapy, 20% received only targeted treatment, and 64% received combination of chemotherapy plus targeted treatment. The targeted treatments among this group, as we just had 44 patients, received not just one drug, but some of them received multiple drugs. And that is shown here, down here. So what is very interesting, the median PFS2 was 50 weeks in the targeted or in the targeted combination group. Here it was 29 weeks, and again in the chemo it was just 15 weeks. So again, it's very important that if you find a target in a particular patient, use it, because the outcome for the patient is likely much better compared to a chemotherapy alone. And if you can combine a targeted treatment plus chemo, even then the outcome is better. When you have targeted treatments and you can combine multiple targeted treatments plus endocrine treatments, then the outcome might be even better. Those are the other trials that were published in 2021 about angiogenesis inhibitors or the mTOR inhibitors. Now, what does a sample report look like? Because you get a lot of information. So it's important to note that such a report can be between 40 to 70 pages. But on the first 3 pages, you get the summary of the whole outcome. So this is what you see on the first page, the specimen analysis summary. Mr. ABC, male patient, in this case bladder cancer. When we did the blood draw, what specimen were analyzed, tissue, blood, and what in tissue was analyzed, FFPE tumor specimen, tumor DNA was analyzed, etc. mRNA was analyzed from the tissue and then blood. TNA was analyzed, 52 genes. CTCs were analyzed, EpCAM, etc. And then you get the outcome which is relevant for the particular treatments. In this particular treatment patient, we have found a high TMB status. So within the guidelines, pembrolizumab is, for example, indicated for this particular patient, but also because here we have found a TMB high status, but using a different clone compared to this clone. Nivolumab would be also applicable. Atezolizumab would be applicable. Avelumab would be applicable. And then off-label therapy, or not within the guidelines, would be durvalumab. MMR proficient, so we cannot recommend anything here. We have found an overexpression in TROP2. This is why sacituzumab govitecan could be an advantage. BRCA mutation was found, but there is no indication for PARP inhibitors. This is why they're here off-label. Maybe it has changed meanwhile for this particular tumor type. I'm not 100% sure. KRAS mutation was found as well in the tissue as in the blood. In the tissue, we have had a minor allele frequency of 73%, and in the blood, 0.3%. Then we have found a PIK3CA amplification, etc. So this is what you find here in the report highlights. Sometimes they can be bigger, sometimes they can be smaller. And then you will also get an idea about the highest mutant allele frequency as a longitudinal marker, so that you can check where do we develop. The numbers of CTCs we have detected, very important. Those CTCs that we are using for monitoring are different compared to those that we are using for chemotherapy. We are using very specific cells, which are EpCAM positive, cytokeratin positive, and CD45 negative for monitoring. And we are using circulating tumor-associated cells for chemosensitivity testing. This is what we have been looking at in all our clinical trials. And there we find much more cells. You can look this up in our publications. There we find per ml blood between 100, 500, up to 1,000, in rare cases, 1,500 cells per ml blood. And this is why we can perform, based on this, all the chemosensitivity analysis. And this is what is shown here. So on one side, we will tell you what is within the guidelines, approved for the particular drugs. Here we are relying on NCCN guidelines and FDA guidelines, cisplatin, because we have found here a BRCA mutation. This is also shown here. This is telling you the cell death rate in percentage. Very important, this percentage will not tell you how much of the tumor will die. It's just a feature to compare cisplatin with vinblastine. Very important. So it's a hierarchical table which tells you which drug is working better. And also we consider drugs usually between 50 and 100% cell death rate as equal, more or less. Between 25 and 50%, we consider them more or less the same, intermediate effect. And below 25%, we recommend not to use them anymore, because in our clinical trials, they haven't shown any effect, or only an effect in a very, very low percentage, less than 10% in the particular patients. And of course, we show you also the off-label therapies outcomes. Later on in the report, you will find this, which tells you the drug response with high response, intermediate response, and no response. Also, for each particular disease, we will tell you disease-relevant findings. These distinguish themselves from breast, from bladder, from prostate, etc. This is why we would need always the exact histopathological outcome upfront to tell you what we have found, also to use then the specific guidelines, which drug can be recommended or not. Then you get some ideas about the pharmacogenetics, if there are any drugs with contraindication, for example, if we would have found a DPYD mutation for 5-FU or capecitabine, that we would not recommend, of course, those particular drugs. And then we have also additional report highlights, indications for non-oncology drugs, if needed or wanted. But also here we would report any pathway activations, etc. There was one of the questions concerns the pharmacoeconomics, and just now we have had 14 abstracts for ASCO, and 5 were also, all were accepted, and 5 were accepted also for direct poster display at the ASCO itself. And what we have seen, this is from the Resilient trial. So this is 6 years, 7 years old, but this is where we have had the best data so far. So the standard therapy in US dollars is usually between 130 to 230,000 US dollar per year per patient. And what we have seen, this was in the resilience study, because there we have had all the data, and it had minimal efficacy because the patients always relapsed. Our profile with EXACTA costs 5 to 8,000 K, because it can depend if you want to add some ctDNA testing, very special ddPCRs or whatever, and replaces multiple single gene tests, which are usually between 500 or 2,000 US dollars. Or when you compare CARIS or a foundation, there's also the price already between 4,000 up to 6,000 US dollars. And cost per progression-free survival per month is 6 to 10K. But the ETA, when we checked for the treatment costs, and standard of care was in this particular trial between 10,000 to 25,000 US dollars. And we also have seen, because we adapted, because of also of pharmacogenetics, we have had reduced neutropenias. And this is also an advantage. So you can say basically that when you're looking at the particular therapy of EXACTA afterwards, you will have an advantage compared to the previous therapy when it comes to pharmacoeconomics. The challenge that we have, as we are looking very often at metastatic patients, they will relapse again. And the longer a patient lives, and this is unfortunately the case, the higher the costs will be. So the question is always, can we maybe apply EXACTA earlier? And we would generally recommend to apply EXACTA whenever the first guideline treatment has failed, or already at the beginning when you have a difficult to treat cancer. I will give you some examples at the end. EXACTA. So we have 99% clinical relevance. What do we mean with this? This means that 99% of the patients we can give certain guidance. We have seen in our clinical trials that we have an objective response rate between 40 to 55%, and we have a longer progression-free survival up to 40% of the time compared to the previous treatments. I also want to speak now 5 minutes about comprehensive monitoring. Why? Because I believe, meanwhile, this is also super important to know exactly if a patient has an ongoing disease or an active disease. And the question is still, of course, how to deal with this. But what clinical trials are at the moment showing also very clearly is that when you find a particular mutation within circulating tumor DNA, act upon this particular mutation. Don't use normal chemotherapies afterwards, if possible. So we are offering this Cancer Track MRD test. In a nutshell, Cancer Track MRD is using tumor tissue, and based on this, we personalize ddPCR. We are using then paired white blood cell sequencing to rule out chips. This is maybe an advantage, not maybe, this is definitely an advantage compared to existing methods. And then you get a comprehensive tissue profiling report, like what you have seen within the sample report I just showed. It can be applied all for solid tumors, and the limit of detection is 0.1%, and because of the ddPCR, 0.01%. And you will get actionable information from tissue and cfDNA. And I don't have to speak a lot about ctDNA. ctDNA, meanwhile, we have every year around 1,500 publications out coming for ctDNA. This was a publication in early breast cancer in 2019. It predicts early breast cancer very clearly. Those are the patients that were ctDNA positive. Those are here the patients that are ctDNA negative. Of course, it's like with every other tool, you don't have 100% security, but it will definitely change the statistics for the patients and will tell you which will have an advantage or not. This is, of course, for colon cancer. For colon cancer, also, meanwhile, 1,500 publications are available. At the moment, we have 500 active or completed trials for ctDNA alone when you look at the databases. So we have, meanwhile, when it comes to ctDNA, which is, meanwhile, if you understand the pre-analytics, a very comparable method where you can find that they have an advantage for the patients. The big question is of course, what to do when you find a patient that has ctDNA positivity in the blood, like those ones. As said before, if you just use the normal chemotherapy, again, the patients will not have a benefit, but it looks like when you perform targeted treatment, it looks like that the patients will have a benefit afterwards. We can skip this for the time being. Also here maybe actionable variants detected in breast cancer cohort, but here also the NCCN guidelines for PIK3CA in the blood, ESL1, NTRK fusions, etc. What does a sample report look like when you have it with ctDNA or CTCs? We will show you the trends in mutant allele frequency for different mutations that we might have found. We tell you the highest mutant allele frequency, but also the other ones. We will also tell you, if wanted, the trends in CTC detection, etc. Where to use then monitoring? If no tissue or a complement tissue for genomic profiling is available, then definitely use ctDNA. Post-surgery molecular residual disease assessment, 2 to 6 weeks later, definitely always recommended, but avoid earlier sampling. Why? Because you can still have, because of the surgery, false positives. Surveillance, active progression. Brain tumor without CSF access, very, very difficult because you will have here only a low ctDNA yield in the peripheral blood. When you already seen that with an early stage, the disease have had no shedding, because then it could be the case that this is a so-called non-shedding tumor, and then ctDNA testing might be very limited for this, or might have a very limited outcome for this particular patient. The summary. Complexity of cancer. Can you apply EXACTA multiple times? Definitely yes. Will the patients have an advantage? Definitely yes. This is a young patient. She was diagnosed with 38 with breast cancer, which was initially ER positive, then only HER2 positive afterwards. And we did really multiple tests from the liver metastasis, from the ascites analysis, analysis from lymph node biopsies, etc. And what we have found was that she have had ERBB2 mutations up and down. And finally, when she received trastuzumab deruxtecan, she had a very, very good response. Unfortunately, she died because of a sepsis in month 78. But this is where she had this particular response, where you can see here that she had severe issues because of this ascites, and which was all clear afterwards, and the patient was doing quite well. Unfortunately, it came a little bit late for the particular patient, but she survived more than 7 years, and she had one goal. She wanted to see how her children go to school, and this is what she finally achieved for 4 or 5 years, basically. Complexity of cancer. This is a poster that we have shown last year at ASCO. What it tells you, you can analyze from ascites, you can analyze from blood, you can analyze from urine, CSF, etc. And the challenge is you might find different targets. In this patient here, very clearly, we have found different mutations in the blood versus the ascites. But because ascites was the bigger issue, we, or the oncologists, acted upon the findings of the ascites. So it might be worthwhile to check also other body fluids, if appropriate, in a particular patient. We can leave this away so far. So what we see, multiple biomarkers definitely complement each other. Comprehensive monitoring also makes sense. Comprehensive therapy management with multiple biomarkers will give you a bigger range of targets that where the patient will afterwards have an advantage, because you can really personalize treatment. Is it state of the art? Definitely yes. Is it standard of care? Partially, because already parts of the EXACTA tests are standard of care. However, the combination of everything is definitely state of the art, but not necessarily standard of care. What are the take-home messages? So it's comprehensive analysis of tumor characteristics using tissue and blood is really possible. You can find a lot which has an advantage for the patient. There is published clinical evidence, and we have ongoing also interventional trials. We have published interventional trials. We have shown in different countries, in India, in Germany, in UK, that patients can have an advantage. Ongoing trials just for chemosensitivity testing are at the moment in Israel. We have another study at the moment ongoing, but it's an observational study in India. The challenge that we all have, that cancer is very complex. which is why I've shown so many pictures about complexity of cancer. But even patients in late stages can profit from our comprehensive testing. We can buy the patient's time. We will not cure a metastatic patient, but we will buy time for almost all of them. And when to apply those tests like EXACTA for cancer drug MRD, I've shown it already, but for EXACTA maybe again in patients with difficult to treat cancers, pancreatic diseases in later stages, but also where therapies have failed among the first line of treatment. This is usually where we see it would make sense to really check what is ongoing in the particular patient, and maybe we find already a target, plus a chemotherapy, plus an endocrine therapy that will help the patient to survive longer, or even to have after stage one, after first line therapy failed, even a cure. So thank you very much so far. I know this was a wild ride. This is our lab on the left-hand side in India. This is the whole building. We have another lab in UK with another 50 people, but there we don't have those nice palm trees. Here on the right-hand side, this is Bayreuth, where our office is. And yes, I'm open for questions so far.
Thank you very much, Stefan, for this insightful presentation and possibility to take a look in many details of the test. It's very useful for us. And I expect the questions. Шановні наші гості, слухачі, будь ласка, задавайте питання.
Мені, будь ласка.
Так, ми вас слухаємо. Чутно?
Чутно, так?
Так. Угу.
Thank you very much, Dr. Schuster, for very interesting presentation. The greatest interest for me and my colleagues is exclusive property of EXACTA, the demonstration of chemosensitivity. So, did I read correctly that you are identifying specific mutations in the tumor cells that make it sensitive to carbon?
Sorry, you were interrupted in between, but maybe I hope I got it completely. We are not looking on the CTCs on specific mutations. We are using for the specific mutations the circulating tumor DNA and the tissue. And for the CTCs, we are just checking the CTC as a conglomerate of different cells. And this is where we are using then directly the chemotherapies and look for the efficacy of those towards the chemotherapies. So we are not using the mutations directly from the circulating tumor cells. I hope I answered your question.
And what is the main idea in the determination of sensitivity?
Sorry,
idea of the determination of chemosensitivity. What's the mechanism of this test?
Very clearly, what we are doing. We are taking the circulating tumor cells with what I have described before. Have you seen the slides that I've shown before? We are taking the apoptosis-resistant cells. We are using then the chemotherapies themselves in a specific concentration, putting the concentration on the circulating tumor cells and checking for 12 hours regularly if those cells are dying or not. And dependent on this, we calculate percentage of cells which were dying. And then we compare this for one drug with the other drugs. Of course, we always have a negative sample without any chemotherapies in there, so that we can really calculate the value of the cell death rate. And this is where we get this hierarchical table with 90% down to 10%. And we have seen in our clinical trials with those 5,000 patients that if we find that the drugs have a cell death rate between 50 to 100%, the response rate in vivo in the patient is usually between 80 to 90%. And when we see patients or circulating tumor cells below 25% cell death rate, then the likelihood that it's working is less than 12% in the patient directly. So this is, the idea is really to check in vitro the efficacy of those chemotherapies, because the challenge is that at the moment in a lot of the patients, it's when you choose the chemotherapy, it works, maybe it depends in which stage you are, if you're in stage 1, stage 2, if you have, what kind of tumor you have, of course. But when you have a relapsed patient and already applied chemotherapies, you will see resistancy. And the question is, against what is this resistancy directed? And this is where you can apply then the chemosensitivity testing. But be careful, use it especially in this scenario in combination with targeted treatments or with endocrine treatments if possible.
Thank you, I get it. And can I second question? Is there this test covered in Germany by insurance companies or German healthcare system?
This is a very good question. At the moment, very clearly in UK, Bupa is reimbursing it. In Germany, private insurances are already reimbursing it. We have some other insurances that where we are in talks with in UK. Also, AXA is taking over the costs for EXACTA and also for cancer track MRD. In Spain, we are in discussions, and also in Switzerland, we are in discussions with insurances. But especially at the moment, it's especially in Germany, it's a very long-lasting interaction that we are in. It's not that easy, to be frankly.
Thank you. And my last question is about clinical practice in Germany. What about situation when EXACTA results recommends administration of medicines in off-label regimens? Can we use them in clinical practice?
Yeah, this is a very good question. Also, when I look at all our doctors that are using EXACTA worldwide, not just in Germany, but from Poland over Germany, UK, Spain, Australia, US, India, it is usually not that super easy to apply a drug off-label. However, especially in Germany, we have the possibility, which is easier in the private insurance field, to apply for off-label use. And in Germany itself, the doctor can apply each drug he wants to apply. The only question is afterwards, will the insurance pay? So in theory, each drug in Germany is allowed to be given. Only the big question is, will the insurance pay afterwards? And this is sometimes the big challenge, because especially when you are in the normal insurance, not in the private insurance, then it can be very, very difficult to get those off-label drugs reimbursed. But we also see after that it's unfortunately not happening after first guideline treatment has failed, but maybe after second guideline treatment has failed, that then the insurances are more open, and then we are helping our doctors also with the arguments to apply for the reimbursement.
Thank you so much.
You're welcome. Any other questions so far? Otherwise, I'm sure that Irina can definitely collect via email those questions, and we can answer them also afterwards later on.
Yes, I think maybe with definitely patient, for example, very complicated, our doctors can have this question, and I can transfer to Dr. Schuster and get the answer. Then now, without other questions, we can make resume of our meeting. Я дуже вдячна всім, хто доєднався.
Thank you so much to everyone who has joined this meeting. And actually, really, if you have some questions with regards to your patients that you manage, you can always approach us anytime. We are ready to give the questions, pass them on to Dr. Schuster for you to get the relevant information, because we understand that only after one presentation you cannot develop all the questions, but you might develop them later, and hopefully you will have this opportunity to use this test, maybe not one, but maybe several, because this lab has a big portfolio. So that is why we have started from 2 tests that are most useful, that are applied most often, but there are more. So I think we will be getting back to other presentations, talking about other tests as well. So thank you. Thank you. Then have a good day, everyone, and goodbye.